everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, welcomes you to our March 2018 End-Use Presents webinar. The End-Use PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. I believe that both of them are in the audience with us this afternoon. My name is Erin Artigiani, End-Use co-investigator. Barbara Kerr, Marwa Al-Nasir, and I will be the facilitators for this webinar. We are all part of the End-Use Coordinating Center team. For those who are interested, you can find detailed information about End-Use, recordings of prior webinars, and invitations to future webinars on our website at www.enduse.org. You will also find instructions for how to join our End-Use network and participate in ongoing discussions with approximately 1,600 experts and concerned citizens from across the United States and many other countries. I hope if you're not already a member that you will join us there, because you will find a wealth of information on a variety of topics like epidemiology, trends, toxicology, drug policy. It's a good forum to just post questions and get advice from colleagues in other parts of the country and share information about what you're seeing where you are as well. We developed the End-Use Presents webinars in particular to work with leading substance abuse experts to explore emerging drugs and drug-related topics. Sometimes these are topics that originate on our network, and sometimes they're topics that we put together in other ways. This month, we are highlighting the diversion and misuse of gabapentin, a prescription medication for the treatment of epilepsy and nerve pain. And this afternoon, we are very fortunate to be joined by two experts, Dr. Mance Buttram and Dr. Jennifer Haven. Dr. Buttram is Associate Director for the Center for Applied Research on Substance Abuse and Health Disparities at Southeastern University, and he will provide a national overview. Then Dr. Havens, End-Use SAG member and Associate Professor for the Center on Drug and Alcohol Research at the University of Kentucky, will present recent findings from her ongoing longitudinal research in Appalachia. This webinar will be approximately 90 minutes long. We encourage you to submit questions during and after the presentations. Please don't raise your hand. Please post your questions in the Q&A box, and we will hold a brief Q&A session after both presenters have spoken. Our presenters, Barbara, Marwa, and I will do our best to get to all of your questions, and we will try to address any remaining questions after the webinar. A recording of this webinar and a copy of both presenter slides will be made available on our website, www.enduse.org. Thank you, and we really hope that you will enjoy this webinar. So, Dr. Buttram, it's on to you.
All right. Well, I'm going to be speaking today, as you mentioned, about gabapentin diversion and misuse. And I have two mini presentations included into one here. I'm going to just give a very brief overview about some of the literature on gabapentin. And from the first study, I'll present data on diversion rates from a national sample of drug diversion investigators at law enforcement agencies. And the second presentation I'll include is some preliminary findings from gabapentin misusers that we've collected here in South Florida. Just as I begin, this first portion of the presentation was funded by Denver Health and Hospital Authority, and there are no conflicts of interest to report. So as Erin mentioned, gabapentin is widely used in neurology, psychology, or psychiatry rather, primary healthcare for the treatment of epilepsy, neuralgia. It can also be prescribed off-label. Off-label uses include substance abuse treatment, mental health problems such as anxiety, and sometimes it's prescribed in combination with opioids for pain relief. Generally, gabapentin is thought to have a low addictive liability level, although a prescription is required. And just in the last couple of years, there's been some changes to prescribing practice. In 2016, the state of Ohio required that gabapentin prescribing was to be reported to their prescription drug monitoring program. And while this drug is not a scheduled substance under the Controlled Substances Act at the federal level, last year Kentucky did schedule gabapentin as a Schedule 5 substance. So what we're primarily interested in was diversion, the unlawful channeling of regulated pharmaceuticals from legal sources to the illicit marketplace. And this can take place in a number of ways. Patients who engage in doctor shopping, sharing medications between family and friends, or even buying, selling, or trading the medication in the streets, or even theft. There is not a lot of literature on gabapentin diversion, and so that was really our primary interest. There is some, I would say, limited findings on gabapentin misuse in the literature, a few case reports, also some epidemiologic reports. And the data really suggests that gabapentin is being abused, especially among people with histories of substance abuse problems and among prescription opioid or heroin users. And some of the literature indicates that gabapentin is being used to potentiate the effects of buprenorphine or methadone among misusers as well. So our aim of this study was to examine gabapentin diversion. As I mentioned, we have a national sample of drug diversion investigators from law enforcement and regulatory agencies. And we had data from the first quarter of 2002 until the final quarter of 2015. And I also included some qualitative data just to help contextualize the diversion rates and case reports that we had. The data are drawn from the drug diversion program, which is part of the researched abuse, diversion, and addiction-related surveillance system. Specifically, the drug diversion program consists of a quarterly survey completed by law enforcement and regulatory agencies. And they report the number of new cases that they had in their jurisdictions during that quarter that also involved prescription drugs. Primarily, we're interested in opioids, benzodiazepines, and stimulants, but the survey respondents have the ability to also include additional substances that are not specifically listed on the survey, and that includes gabapentin. Cases that they would report could include anything from if an investigator is engaging in a street buy, or someone is arrested and they do a search and they have a large number of prescription pills. They find someone that is forging prescriptions, that kind of thing. The study currently includes approximately 250 investigators from 49 states, all states except Hawaii, and it covers about 1/3 of the total US population. And as I mentioned, we wanted to contextualize some of the case reports that we had in the quarterly surveys. So in April of 2016, we sent a small qualitative questionnaire to our survey respondents, asking if they had seen anything about gabapentin diversion or misuse in their jurisdiction, and to provide any additional details if they had that. This is a look at the data. We took the cases for each quarter and we computed a diversion rate per 100,000 population. And what you'll see is in the first 2 quarters of 2002, the diversion rate was 0. We had 0 cases. And this gradually increased to a high of 0.027 cases per 100,000 population in the final quarter of 2015. We had in total 407 cases of gabapentin diversion across 41 states during this time period. And this is a statistically significant increase. And I think what's interesting about this chart is you can see really the escalating diversion rates begin to pick up in the final four or so years of data collection. For the brief questionnaire we sent it to 241 participants. 73 of those responded to us, and we had a total of 21 participants that described their experiences with gabapentin misuse and diversion. The remainder of respondents said that they did not have any additional information other than what was in the survey that they submitted, or that they had not seen any gabapentin diversion in their jurisdictions. Cohering with some of the literature I mentioned earlier, we had our participants note that abusers, as the first one says here, many abusers stated they would take gabapentin with opioids to increase the duration of the high. This was a common sentiment that we received. And at the time, we were somewhat surprised to see our reporters mentioning that gabapentin misusers are combining with heroin and injecting that compound. And we had those reports from Alabama and Louisiana. Participants also added a little bit of additional information about diversion, how gabapentin was specifically diverted. Cases involved theft, doctor shopping, illegal online sales. And we had just a few of our participants that mentioned the street value. One participant from Kentucky noted that patients learning of its street value and are selling it and trading it for narcotics. And another one from Michigan who noted that it can be bought for about $10 per pill. So in this study, we documented an increasing national rates of gabapentin diversion from 0 cases in 2002 to 0.027 cases per 100,000 population by the end of 2015. And to put this in context, you can compare this to a diversion rate of 0.021 cases for OxyContin branded oxycodone in 2015, and a combined rate of 2.5 cases for 6 prescription opioids, branded and generic. And those include oxycodone, hydrocodone, hydromorphone, fentanyl, morphine, and tramadol. So while gabapentin diversion rates don't approach the rate for opioids in general, I think the increase in gabapentin diversion rates, and especially the increase in the latter years of data collection, really suggests that this is something that we should do continued surveillance and research on. And finally, as I mentioned, this was the first report that we had seen where gabapentin was being combined with heroin and injected. Again, something that is somewhat concerning and definitely is going to require some more research. Population estimates of gabapentin misuse in the United States are not apparent, but I pulled some of these statistics, and what we see is that up to about a quarter of prescription opioid misusers and maybe up to about 2/3 of people with a gabapentin prescription in several studies report using gabapentin not as prescribed. And as Dr. Havens will mention, I'm sure, in a study among non-medical opioid users in Kentucky, there was approximately 3,000% increase in gabapentin misuse between 2008 and 2014. So again, I think this adds support to our diversion data that this is potentially a very growing problem. So looking at our data, we're really focused on trying to get some additional epidemiologic research and research conducted among gabapentin misusers. And I'm going to talk about that in just a minute in the next piece of this presentation. But additionally, post-marketing surveillance of gabapentin diversion is really important. And I anticipate, as our survey has continued since 2015, that very soon we'll be able to update these diversion rates beyond 2015 and keep an eye on diversion rates and where that trend is moving. I added this slide here. So these data have been published just recently, and there are more details about methodology, the drug diversion program in this publication. So if anyone is interested, I would encourage you to look at that. And I included a few citations here if anyone is interested in those as well. So next I'm going to talk about a study that we just began at our center here in South Florida, looking at gabapentin initiation among those who report recent gabapentin misuse. And this is a NIDA-funded study, and there are no conflicts of interest to report. And the aim of this study is to examine the decision to initiate gabapentin misuse. And to do that, we're doing mixed method interviews with 60 gabapentin misusers. And today I'm going to be talking about the qualitative portion of that interview, which typically lasts about 30 to 45 minutes. And as I mentioned, the focus is primarily on initiation. Although we have related questions about motivations for use, the specific context where it was used, route of administration, and additional substance use as well. So I mentioned that we had just begun this study and we only have 6 participants to date. So we haven't done any comprehensive data analyses, and we just have a handful of participants. So these findings are preliminary, but I thought they might be of interest to the audience today. Our sample, as you see here, is fairly diverse. 2 Hispanic men, a Black woman, 2 white men, and 1 white woman. The mean age is 30. All of these participants report their primary drug use being heroin, except for participant number 6, and her primary drug of use was cocaine. One of the first things we started hearing from participants, 2 men mentioned that they use gabapentin not as prescribed, as what they called a self-detox. And both of their stories were very similar. So I included some quotes from this participant here. He said that he first learned about gabapentin at a substance abuse treatment center. He said, they gave me gabapentin. It kind of worked for the detox. So from then on, I knew when I wanted to detox, I would go to my primary care physician. He says he has a bad back, so the doctor never had an issue with giving him the gabapentin. I think this speaks a little bit to the ease with which he was able to get a prescription from gabapentin, and that was something we heard from all of the participants. And as far as detoxing go, both men described it as helping with the anxiety of not having a drug to take, and helping a little bit with physical pain. And both of them said that this is a practice widely known among opioid and heroin users, as this participant said, as seasoned junkies detox. We had 2 participants that used gabapentin to mitigate withdrawal symptoms from other drugs. So the first participant, she told me that after using cocaine, she would be, quote, off to the races if she took gabapentin. So she would wake up and not have any withdrawal symptoms and feel really good and ready to go the next day. The second participant described his initiation process. He says, I had been using Percocets, and he had a bunch of gabapentin, which was prescribed to him. So I ended up taking a handful to try and not be sick from withdrawal. I would note that both of these participants said that they used gabapentin primarily because it was more accessible and available to them, while their preference would have been another drug such as Xanax, or for the second participant, another opioid, rather than gabapentin. And then finally, we had several participants that used gabapentin specifically to get high. 2 participants, one a Black female and one a white male, described it as being somewhat common to use in halfway houses. That's where they first used it and came to know that it could be misused. And primarily it's because there's no other drugs available to them. So gabapentin is something that they said they would stockpile and then take very high doses of in order to feel a small buzz. I included some quotes from this participant here who is from Kentucky and initiated gabapentin after he had already been misusing buprenorphine. And he says combining those 2 was like a cocktail. He says it's like Suboxone is fire, gabapentin's oil, and you're throwing oil on that fire and it enhances the buprenorphine so much. Again, he commented about the ease with which he could obtain diverted gabapentin, or even obtain a prescription simply by saying that he had fibromyalgia pains. And he was the only participant that we had that reported gabapentin injection. He says it was a difficult process, but when he did do it, he combined it with heroin. And he said, I remember the first time I shot gabapentin up, it was like I had just taken heroin again. That first time came back to me. Gabapentin, among this very small sample here, appears to be well known in their communities, easily accessible, and especially known among opioid users. And I would say most of the participants said to us that it is not necessarily a drug of choice to get high, but it's rather something when it's available and other things are not. It tends to be a go-to drug for them. And all participants described the ease with which they could get a prescription, either legitimately or if not, feigning nerve pain or anxiety, something of that nature. We had one participant whose first experience with gabapentin was prescribed to him, but all others, it was not. And what I found interesting was that they all ended up getting a prescription for gabapentin at some point, either going to detox or substance abuse treatment, jail, or having legitimate pain. So we're continuing the study, as I mentioned. We just got started, so we're going to be looking at initiation, the relationship of gabapentin to opioids and heroin, and some additional social and environmental measures. The final phase of this study will also include in-depth interviews with prescribers and substance abuse treatment professionals to get a better understanding of prescribing practices, how the decision is made to prescribe gabapentin to who and why, and also the experience people have in having gabapentin misusers in treatment. So those are all the data I have to present today, but this is my contact information, and please feel free to reach out to me, and I'm happy to answer any questions or give any additional information in the future.
Okay, Dr. Havens, you're up next. Thank you very much for that presentation, Dr. Buttram. That was very informative, and I'm sure we'll have some questions come in from folks looking for some additional information.
Fantastic. Thank you so much. And that was a great introduction, Dr. Buttram. I'm going to be talking about the emergence of gabapentin as a drug of abuse in a cohort of rural Appalachian drug users. And I'd like to note that the majority of this research was conducted by one of my doctoral students, former doctoral students, who's now on faculty at the University of Louisville, and that's Rachel Smith. So the goal today is to describe the epidemiology of gabapentin abuse and misuse and examine both gabapentin abuse and misuse in a cohort of rural Appalachian drug users, and talk about what the next steps may be in helping to mitigate some of the harms associated with gabapentin misuse. So I always include this slide in all of my presentations because I think it's important to note the financial burdens and the economic disparities that are happening in Appalachia. And in fact, these are the fiscal year 2015 data, and many of those orange counties in Kentucky have now even turned red, so from at-risk to distressed. So these are some of the poorest counties in the United States, which I think it's important to remember when we're talking about prescription drug misuse and diversion. So Dr. Buttram talked a little bit about this study that was conducted by Dr. Smith. It's a review, and I'm presenting it first, but it really came after the first paper that we published. And it was a literature review to examine what data were in the literature about the misuse and abuse of gabapentin. And for the purposes of the manuscript and the search that was conducted, It was taking larger doses than prescribed, taking without prescription, and certainly diversion. And at that time, in late 2015, Dr. Smith was able to identify 23 case studies and 11 epidemiological studies that met inclusion criteria for the review paper. We found papers from the US, the UK, Germany, Finland, India, South Africa, and France, more from Europe, certainly than the United States, and only one study had actually done an estimate of the national prevalence, and that was in the United Kingdom, and they estimated the prevalence of gabapentin misuse to be at just a little over 1%. And like Dr. Buttram mentioned, the prevalence certainly higher in samples where folks were abusing other prescription drugs or illicit drugs. However, interestingly, lower than expected prevalence of gabapentin abuse among those who were alcohol dependent. And I know that they were examining using gabapentin as pharmacological therapy for alcohol dependence, so this makes sense. However, they did find higher prevalence among those with opioid dependence. So several of the studies were postmortem or toxicology studies, and many of them found that gabapentin was identified in the toxicological reports. And very interestingly, in a study where they were examining the toxicological results from a study of US drivers, they found just under 1% to be positive for gabapentin. And I think this is consistent with some of the literature, certainly from the rural areas of Kentucky, where we find that more folks who are pulled over for drunk driving are actually under the influence of other drugs versus alcohol. So I thought this was interesting, though, that I think this is a fairly high number for those positive for gabapentin. So the study that we've been conducting since 2008 is a longitudinal study looking at the vulnerabilities to prescription opioid abuse and its associated harms in rural Appalachia. It's called the SNAP study, or Social Networks Among Appalachian People. And the purpose of the study is to determine the prevalence and incidence of hepatitis C, HIV, and herpes simplex 2 in relation to social network characteristics among rural drug users. We've been following folks again since 2008. And we will be following them through 2021. And we're still actively following about 430 of the original 500 whom were recruited back in 2008 to 2010. So this is our storefront location, purposefully vague. We don't necessarily want folks to know what's going on here, but it's a small town, so everybody knows what's going on here, not surprisingly. But again, we didn't want to have Center for Drug and Alcohol Research, because what ends up happening is people knock on the door and say, do you have drugs? So again, participants know where we are. Most of the folks in town know who we are, but at the same time, we try to keep it nondescript to protect the confidentiality of our research participants. So the eligibility criteria for the SNAP study were age 18, English speaking. All of our initial seeds, we used respondent-driven sampling, were people who inject drugs, and that's because our primary outcomes were around some of the infectious diseases, prevalence and incidence. And they needed to use at least one of the following drugs to get high in the prior 30 days: prescription opiates, cocaine, heroin, methamphetamine. But every single person that walked through the door in 2008 to 2010 was abusing prescription opiates, at least, if not also cocaine, far less heroin and methamphetamine. So oftentimes in studies where you're eliciting responses about highly sensitive behaviors, we'll use a CASI. But in this case, we felt it was really important to establish rapport with our participants. So we have an interviewer-administered questionnaire where the responses are entered directly into CAPI, computer-assisted personal interviewing software. We do serologic testing with pre- and post-test counseling. All rapid tests, we're giving our participants their results on site. HIV, HCV, HSV2, and then more recently syphilis from the follow-ups we've been conducting since November. So we've expanded the ASI, or the Addiction Severity Index, which is commonly used in research and clinical studies to measure drug abuse. And since the second follow-up visit, so 2010 and later, we've been including gabapentin specifically. So we do have an other question, and that's how we originally discovered that gabapentin was being named, I would say, above and beyond what we would expect. for a study of prescription drug abuse, which is why it received its own category in 2010. We're also able to get demographics from the ASI. Since this is also a network study, we use a name-generated questionnaire to measure drug, sex, and support networks, and we're able to generate sociocentric networks from those data. And finally, we use the risk behavior assessment to determine sex and injection risk behaviors. So at baseline, keep in mind baseline was now anywhere from 8 to 10 years ago. So predominantly male, our median age at the time was 31. So we will begin to recruit an additional 250 young drug users starting in the next several months. And that's because, not surprisingly, we have an aging cohort. Consistent with the demographic characteristics of Appalachia, the majority of our sample are Caucasian, few employed full-time, and again, by design, most had a lifetime history of injection drug use. So interestingly, we're really seeing different patterns of drug abuse for those who came into the study who are considered younger drug users, so those under 30 and those over 30. We see that the younger drug users are beginning to use marijuana and alcohol at age 13 and 14, but then while they're still high school age, they're exposed to benzodiazepines, hydrocodone, oxycodone, and even to some extent OxyContin, while it was still available in the older formulation, crack and cocaine, whereas we see the older drug users weren't exposed to many of those drugs until they were out of high school. So looking at drug use over time in our cohort, we see in 2008, certainly we didn't have anybody who was indicating gabapentin abuse, although when we did some of the qualitative work I'm going to present a little later, most note that it's been around, certainly for an extended period of time, and they've been aware of it, but not necessarily as a drug of abuse. But really what we've seen is this explosion in the number of folks who, or the proportion of folks who indicate past 30-day use of gabapentin. In 2008, again, no folks reporting use, and in 2016, almost half of the sample indicated they'd used it at least once in the past 30 days. Again, we see that heroin is not widely abused in the cohort. That is still true today, and that has a lot to do with the availability. It's not generally available regularly in the county that we're in. We've seen declines in OxyContin abuse, which again is not surprising given the formulation change. We certainly still do see a whole lot of roxicodone abuse, so that's immediate release roxicodone, which can be injected because it's a mono formulation. And we've seen declines in most of the drugs of abuse, but at the same time, most of our participants are still reporting abuse of at least one of the prescription drugs. What's happening now, though, is they're not using necessarily multiple prescription drugs. And again, gabapentin, as of 2016, was the most popular drug of abuse. So as Dr. Buttram mentioned, we've seen a 3,000% increase in abuse between 2008 and 2014. And just in a one-year period, we saw a 165% increase. And participants are using almost daily. They're reporting a mean number of days of use of 25 of the past 30. And not surprisingly, they're more likely to also be abusing other drugs, and specifically immediate release oxycodone or roxicodone, buprenorphine, as well as benzodiazepines. So as part of Dr. Smith's dissertation, she did a qualitative analysis, and these data were collected from 2 active cohorts in Appalachian, Kentucky, which were both funded under NIDA R01s. The eligibility criteria for both of the studies were, or at least for this specific qualitative study, was recent gabapentin abuse, so within 1 year. So we were able to recruit 33 participants, 5 males and 27 females. And it should be noted that the second cohort, not the SNAP, but the WISH cohort, is all females, which is why we have a larger proportion of females in the study. Across 4 focus groups that were conducted at the field site in Hazard, Kentucky, between March and September of 2015. So when we asked about initiation, most indicated that they had initiated gabapentin between 5 and 10 years ago, and most likely the source was for a prescription for nerve-related pain, as Dr. Buttram indicated, or mental health disorders. One of the quotes from the qualitative analysis, that's how everyone got introduced to gabapentin. It's through doctors. However, family and friends were also mentioned as the initial source of gabapentin as well. So again, reasons for first use, very similar to the initiation, legitimate medical concerns, but they also heard about it from peers. So one of the quotes, I mean, it's more and more and more. As years went on, people just started gabapentin. You'd hear other people talking about them, and I was like, well, let me try it, and it went from there. Really interesting, we had two very divergent camps, if you will, about the physical experiences from gabapentin. So Dr. Buttram talked about reports like a shot of cocaine, so stimulant-like effects, which is very different from what is reported, at least in the side effect profiles, where you'd have muscle relaxation, pain reduction, sleepiness, or a feeling of drunk or high, or likened to that of opiates. And then other folks were saying, this is the only way I can get up in the morning. It's what we use to get up and go, which I thought was so interesting, because those are two very, two reports that are very contradictory to each other. Motivations for continued use were primarily for the psycho or the pharmacodynamic effects or getting high. Other reasons for continued use, certainly pain relief and the ability to continue to get a prescription from physicians. Also withdrawing from other substances such as cocaine, buprenorphine, and oxycodone. And then getting high with gabapentin, it was reported as cheap and always available. And Dr. Buttram indicated that the street value was as high as $10. Now, certainly earlier reports indicated that most folks were getting it for free or about $1 a pill, but the prices have certainly gone up since then, and now we're hearing reports similar to what Dr. Buttram reported of $5 to $10 a pill. The characteristics of abuse, use of tolerance to enhance the high. So one of our participants indicated that you would wait a few days and don't take any, then you take some and you feel good. And we are certainly not seeing any injecting of gabapentin in this cohort, or at least among those who we were able to talk to for the qualitative study. Primarily oral use, some snorting, and many reported the effect was enhanced with concomitant use of caffeine, and also reports of folks using it as a way to come down from cocaine. So again, physical effects, reports of both stimulant-like effects and depressant effects, which is fascinating. So we also had reports of weight loss, quite extensive weight loss in several of the participants in the qualitative study. There were about 75 pages worth of transcripts from this, and really it read like a script from Days of Our Lives. It was really interesting. This is some of the most fascinating qualitative work I think we've ever done specific to gabapentin abuse and misuse. And when we asked our participants about longitudinal trends, they indicated there was longstanding awareness of the drug, but have noted an increase in popularity in just more recently, so in the past 5 years or so. And they indicated that there was more use among younger drug users, and there was concern at the time in 2015 about it becoming scheduled, which it did in July of 2017. And one of our participants said, and that's why they're gonna make them scheduled, because everybody's getting them. So we've certainly seen many changes in laws to curb opioid abuse and other prescription drug abuse, and we've certainly seen shifts in abuse patterns potentially as a result of some of these changes in the laws and practices. So certainly changes in the opioid epidemic have shifted much of the abuse from prescription drugs to heroin, somewhat mitigated by the changes in the laws and practices, which ended up increasing the scarcity of prescription drugs. And similarly, changes in laws around opioid prescribing and PDMPs may also be driving the use of gabapentin in rural areas. So certainly we saw as OxyContin and IR oxycodone became more difficult to come by, we then saw the uptick in the abuse and misuse of gabapentin. However, gabapentin is now scheduled, as I indicated, as of July of 2017. So interestingly, we'll have data to demonstrate how this has affected use longitudinally. We are back out in the field as of November, which is obviously after the law took place, the change in the law took place and the scheduling took place. So we are in the first 80 or so folks we've interviewed, we have seen decreases in reports of gabapentin abuse and diversion. So hopefully we will see the effects that we hope it has. But what we're also seeing now is a shift back to the opioids of abuse, such as IR, oxycodone. So again, those unintended consequences that hopefully we will be able to measure and report back on here in the next year or so. So what are the next steps? Certainly we want to continue to examine these longitudinal trends in gabapentin abuse and misuse. I think it's really interesting to have different geographic contexts, which is why I think Dr. Buttram's work is so important, and certainly he's not in rural areas like we are, so we'll have, I think, some really nice data that can compare and contrast what's going on in two different areas of the country. And I'm very interested to see what the effect of the changes in scheduling has had on abuse and misuse of gabapentin longitudinally in a cohort of drug users. And we'll also be able to see what the prevalence of use and abuse is among the young drug users when we recruit that newer cohort, and see if there are any differences in the young drug users versus our older cohort. And once again, we'll be reporting back to policymakers around the implications for other states with PDMPs who are contemplating scheduling or requiring mandatory reporting to the PDMP like they've done in Ohio. We'll also continue to examine drug co-usage with opioids as well as stimulants. We're starting to see an uptick in methamphetamine abuse in this cohort, so I'm curious to see whether, similar to reports of using gabapentin to come down from cocaine, whether we'll see that as well with methamphetamine. And I think I'm also very interested in seeing whether the motivations for use and certainly the sources of gabapentin change over time as it becomes more scarce, likely as a result of the scheduling of the drug. So I need to acknowledge NIDA and NIH and Dr. O'Brien, who is on this call as well. She was one of our early project officers for this study. And specifically Drs. Leffwell and Walsh, who have been instrumental in helping us to examine the human behavioral pharmacology of gabapentin. And interestingly, you know, some of the early studies certainly did suggest that gabapentin had low abuse liability based on these human behavioral pharmacology studies. And with them both being behavioral pharmacologists, they were certainly able to help Dr. Smith and I to interpret some of the results that we've seen. And again, this was initiated by Dr. Smith, and she's going to continue to look at this. We're looking at longitudinal trends in this cohort, so some of the demographic and drug use characteristics over time. And she's also doing some interesting work with some of the large nationally available side effect databases that looking specifically at gabapentin, reports of gabapentin, some of the more serious side effects that have been reported. And certainly our study staff and Hazard and our study participants who we have 90 to 95% follow-up rates over time, so we can't thank them enough for their continued interest in participating in our work in Hazard, Kentucky. Thank you.
Okay, thank you so much, Dr. Buttram and Dr. Havens. You certainly provided us with a great deal of valuable information about gabapentin. And we have had a few questions come in, and I will get to them in a moment. And so our first question that came in is from an attendee who asks, have you looked into diversion of gabapentin from veterinary prescriptions? Either of you are welcome to answer that question.
I have not. Mance, have you heard reports from veterinary?
In our survey, we do have veterinary boards that report. That tends to vary by state. Mostly it's law enforcement agencies. I would have to go back and see if any of those specific participants reported gabapentin diversion. But I think that's a very, very good question for sure.
Yeah, we do have an other category as well in our source data, so we can comb through that and see if we've had any reports of the source being veterinary clinics. Although most of the time they indicate that it came from, now the dealers may be getting it from veterinary clinics, but if they received it from a dealer, then there's no way for us to know the initial source. But we can certainly comb through our data and see if we have any reports from veterinary clinics.
Okay, thank you very much. This next question, Dr. Buttram, is for you. It's from an attendee who wants to know a little bit more about how you recruited your subjects.
We recruited the subjects in the second portion, the substance users, through a variety of means. These participants all came from local substance abuse treatment centers. So we interviewed them there. As far as for this first study, the law enforcement agencies, those are recruited at different conferences. We do a lot of one-on-one outreach to police departments, and then a lot of word of mouth also. Police officers will tell other police officers, and we get participants that way.
Okay, thank you very much. And just as a reminder for everyone, yes, we will make a copy of both of our presenters' slides and a full recording of this webinar available on the NDUS website, which is www.ndews.org, www.ndus.org. So give us a week or two to get everything edited and put together and put up there. And in the meantime, you will be interested to know, I'm sure, that the recording from our last webinar in February, when we were joined by Jill Head, supervisory chemist at the Drug Enforcement Administration Special Testing and Research Lab, presented on their newest information on emerging drugs and trends, and that is available on the website now, soon to be followed by a copy of her slides as well. So to get back to your questions, we have one now from a participant who asked, does the use of gabapentin with an opioid increase the risk of overdose? For example, is it actually increasing the potency of the opioid, or does it just feel different to the user? So do either of you have a thought for a response to that question?
Well, I'm not a clinician or a pharmacologist, so I cannot really speak to that. I would think not, but that's not my area of expertise.
And I would agree with Dr. Buttram, which is why we had a couple behavioral pharmacologists working with us on this project. But I would say that certainly gabapentin has been identified as one of the drugs in several toxicological postmortem studies. So it's not out of the realm of possibility that it increases the potential for overdose. But again, I can't speak to the pharmacology of concomitant use of both of those together as an increase in risk for overdose.
Okay, thank you. Now we have a question. It's actually two questions from another participant. His first question is, what information do the presenters have on off-label prescribing of gabapentin by itself for pain relief versus off-label, prescribing of gabapentin with prescription opioids for pain relief?
That is something that I actually don't know very much about. As I mentioned in the study we have now, that's one of the key aims is to interview prescribers to get a better understanding of how they make that determination, whether or not they'll prescribe gabapentin only or in combination with an opioid.
Certainly we're hearing that that is one of the things that is driving the availability of gabapentin is the shift away from prescribing of opioids for pain to drugs that were thought to have low abuse liability, which we're finding out a little too late that that is not necessarily the case. As mandatory reporting to PDMPs was coming down in Kentucky, we did see that shift to the prescribing of non-opioids for pain. And oftentimes that's not done in conjunction with an opioid for pain. So we're seeing, at least in the reports from folks in our cohort, it's one or the other.
Okay, the next question is, what information can the presenters provide about pregabalin, Lyrica, diversion versus gabapentin diversion. Is that anything either of you have looked at?
We have in our survey some data about pregabalin diversion, and we did look at that. I think pregabalin is a scheduled drug, so it's not as easily, I guess the diversion rates are not as high for that drug because it is scheduled and gabapentin was not. So I think I would have to look at the prescribing data, but we definitely saw much bigger rates of gabapentin diversion and much more increases in gabapentin diversion. And pregabalin was something that was there, but never really had high numbers.
Yeah, I would echo exactly what Dr. Buttram said. Certainly we do have reports of pregabalin diversion and misuse, but not nearly at the rates of gabapentin abuse and diversion. And that has everything to do with the scheduling of the drug and greater availability of gabapentin. Up until recently, it was scheduled in Kentucky just because they were able to get it much more easily on the street because it was not scheduled.
Okay, thank you very much. And now we have a question that I think Dr. Havens is directed to you, and hopefully there's enough here for you to work with. It's a question from a participant who asks, how can we explain this opposite side effect in different users?
That's a great question that we are going to leave, I think, for our human behavioral pharmacology study colleagues. And that's something that I think they're really interested in doing. This is a rare drug where I think we need to go back into the laboratory and we need to do the studies that they often do before a drug is even marketed and redo these studies, because what we're hearing are from our participants who are using this drug often in super therapeutic doses. So not what necessarily is being prescribed and what was even being used in terms of a dose in those early studies. And we're seeing just these incredible side effects that we wouldn't normally expect. And again, that would be certainly the stimulant-like effects, weight loss. So really different reports from different people. So I think we need to go back to the lab and see what's happening there at different dose levels, people who are using different drugs concomitantly, and see what's happening, because I don't think we understand nearly enough about this drug that we thought we did until we started hearing reports of abuse and diversion.
Okay, thank you very much. I think this next question is for you as well. This is from an attendee who asked, beyond poverty issues specific to Eastern Kentucky and Appalachia, are you aware of any other reason gabapentin abuse is concentrated there versus other locations in the U.S.?
Well, certainly Dr. Buttram's seeing it in Florida as well, but I think that there are obviously several industries. So many of the things that led to the prescription opioid epidemic, kind of the epicenter being in Appalachia, are very similar for gabapentin as well. You have a lot of industries that are very labor-oriented, where you have a lot of pain. We have some of the highest rates of diabetes. This drug is also prescribed for diabetic nerve pain. So, you know, we have a lot of the conditions that it's being prescribed for, which led to an exacerbation and increase in the number of pills that were on the street, certainly.
And I would just add to that, we, through our diversion data, seen reports of gabapentin diversion across 41 states. So it may be also that people just are not asking about gabapentin misuse in other parts of the country, and we may see that it actually is more widespread. But I think, you know, that's a good reason to continue researching it to see.
All right, thank you very much for that. So now we have a question from an attendee who asks if you both have any thought about what the next wave of prescribing might be that would tend to be vulnerable to non-medical use. So, for example, a substance mentioned by another attendee was lamotrigine. Would you expect anything to happen there?
We, again, are just back out in the field. And so we are always looking. I mean, that's how we figured out gabapentin was problematic, is actually my interviewers, if they hear a drug being mentioned more than a couple times by several participants, they'll call me and say, hey, what's this drug? And, you know, I think we should be asking about it because it's being mentioned under the other drug category by multiple folks. So that's not one I've specifically heard of, but once we have about 200 or so interviews from this round, we should get a good sense of what the trends are and if there are any new emerging drugs of abuse. And that's why NDUS is here, so we can let you guys know and tell other folks to be potentially on the lookout.
I would say just, we just went back out into the field also, and I think one of the drugs that's been mentioned among drug users that we've interviewed, and also in some of our diversion data, are muscle relaxants. Risperdal is one, Soma. So I don't know if that is the next big problem, but certainly one that I've been seeing mentioned more often.
Okay, thank you very much. We have another attendee who wonders if either of you have heard of any gabapentin-related fatal overdoses.
That's not something we have looked at.
I saw a colleague of mine at our center had some medical examiner data from some counties in Florida, and certainly gabapentin was mentioned, but it was never the only drug that person had taken. It was always in combination with an opioid. So I think I haven't seen that at all.
Okay, so following on that comment on how people often have multiple drugs, so we have another attendee who asks if in your research you have found any evidence of gabapentin adulteration of heroin or other illicit substances.
That's not something we test for, but we will ask whether folks are taking drug in combination and specifically taking drugs together. And the only reports we've had so far are of buprenorphine and gabapentin being taken together.
I would say the same thing. We've seen gabapentin and buprenorphine taken together. And as I mentioned, we had 2 law enforcement reporters who mentioned heroin and gabapentin consumed together. But I haven't seen, none of our law enforcement participants have mentioned heroin being cut specifically with gabapentin.
Yeah, we're not hearing about the adulteration, certainly, of heroin or other drugs with gabapentin.
Okay, so now we have an attendee who wants to know if you are seeing pushback from the jails, treatment centers, or methadone clinics from doctors, for example, when you tell them about the misuse or diversion of gabapentin. This person shares that some of the doctors in parts of Maryland are unwilling to hear that the prescription is being abused at all. I guess just wants to know if you've noticed anything comparable where you are.
Yeah, I don't think at this point many of the doctors we talked to are surprised. All of a sudden they were starting to get requests, and usually when there's requests from the patients, that means that there's some street value for it and that there's potential for diversion. So certainly in 2012, 2013, when we were starting to hear about widespread abuse and diversion, that may have been shocking, but I think these days it's not surprising at all to any of the healthcare providers that this is potentially a drug of abuse, or is a drug of abuse and is being diverted.
Okay, thank you. We have a question here from one of our attendees who asks, when Kentucky scheduled gabapentin, can you talk a little more about evidence that there was switching back to opioids?
Well, that's from our data specifically, and that's, again, that's just the first few people that we've interviewed. But I asked specifically our study director and our interviewer whether we were still seeing the same high reports or high rates of gabapentin abuse and misuse. And they said, actually, we're starting to see folks go back to roxicodone. But again, that's just the first few folks. Once we've interviewed 200, 300 out of the 430, we'll have a much better idea of what the true trends are, because, you know, with respondent-driven sampling, they're recruiting their peers into the study. So a lot of the first 20, 30, 40 people in our study are all in one component of this larger drug-using network. So I'm not surprised that folks who are all interrelated in their drug use habits would be using similar drugs. So once we get out of that first main component, we may see completely different trends. So I'm hesitant to say that, you know, we're going to see that shift back to opioids, but that's what we've had the first 40 or 50 folks we've interviewed have reported back to using IR roxicodone versus gabapentin after the scheduling.
Okay, thank you very much. I see that we have a number of questions coming in, so I know we're not going to get to all of them. I'm going to just pick a few more now so we can start to wind things down. And so I have a question here from an attendee who says, have either presenter had reports of gabapentin being diverted to be used in conjunction with methadone?
Yes. I've heard that from a few of the participants that I've spoken with. And I've seen that in the literature as well.
Yes, I think I was going to echo that we've really only seen it in the literature search that we did in the review paper. There were some reports, I believe, from Scotland where they were using it with methadone, in conjunction with methadone.
Okay. And we have one attendee who wants to know what recommendations you have for primary care prescribers regarding the use of gabapentin, if any.
I think it would be very similar to opioids. You really have to look at their history and whether you think they would potentially be a candidate for abuse and diversion. So it's going to be a case-by-case basis, but certainly the literature shows it is an effective medication for nerve pain. And it's certainly been used for other conditions off-label very effectively. So I think it really, you know, I don't think we can have some sweeping statement about it, but certainly on a case-by-case basis, just like you would do with opioids.
Yeah, I would echo the same comments.
Okay. So here's another question. Do you think the divergent effects of gabapentin you mentioned might be analogous to how individuals with ADHD and those without respond to different stimulant medications? I think Dr. Havens, this one was directed to you.
Yeah, it very well could be. And I think that that's one of the reasons we need to get back into the lab to be able to do these kind of studies, because again, this is all, you know, anecdata. So this is just reports from, you know, from individuals, but certainly in reading the transcripts from our focus groups, you know, once one person mentioned it, it was echoed by multiple other participants in the room. So I don't think it's unique to one or two people. They said, yeah, that's how I get up and go during the day. And then other people, you know, kind of laughed it off and said, oh my gosh, it puts me to sleep the second I take it. So I think there clearly is something going on there. But there's no way we can use, I don't feel we can use the data that we have from an epidemiologic standpoint to be able to make any conclusions, to draw any conclusions about how different people are affected by use of the drug.
Okay, thank you very much. So we just have a couple more questions. One is, did you find that antidepressants can influence the physical effects of gabapentin?
We don't have any data on that. I don't know, Mance, if you do.
No, we don't. I'm not sure.
Okay, so one last question here is from an attendee who wonders, is there a specific dose that abusers prefer? Have you heard anything about that in your interviews?
I've heard that it's typically very high doses, 2,000 milligrams or more. And, you know, some participants would say I would take 5 to 6 pills at a time, you know, or more. And I think you build up a very quick tolerance to it. So I think it takes a lot.
Yes, very similar reports from our participants as well.
Okay, well, thank you for very much for all of that and for taking the time to answer all of our questions from our participants and attendees. We certainly appreciate that. And right now, I hope that those of you who have stuck with us will take a couple moments to complete a quick poll for us and just answer a few questions so that we can get some ideas and suggestions from you about what you'd like to hear about in the future. And in the meantime, I will fill you in on what we have coming up. And in April, on Tuesday, April 10th, at a special time, starting a little bit earlier, 10:30 a.m. Eastern, we're going to be joined by two experts from the United Nations Office on Drugs and Crime, UNODC, who will provide their latest information on NPS, or novel psychoactive substances trends at the global level, information about new toxicology module of the early warning advisory on NPS, and more. So I hope that you will be able to join us for that again then, as we'll be continuing our exploration of emerging drugs and changing drug trends. And coming up after that, we're also working on putting together some webinars on vaping, and then another one where we'll be joined by experts from the CDC who will talk about some new data resources that they are working on putting together. So it looks like a number of you have participated in our poll. I'll just give you a little bit longer. And again, thank you so much, Dr. Buttram and Dr. Havens, for joining us today. You did great presentations and really gave us a lot of valuable information and helped increase our understanding for gabapentin and how it can be diverted and misused. So that's certainly something that we will all continue to keep an eye on, and I hope you'll keep us posted on your research as well, and certainly let the End News Network know when you have additional articles or reports released, because I'm sure folks will be interested in that.
Well, it was a pleasure. Thank you for having me.
Yes, thank you.
All right, so looks like things are slowing down, so I will thank you everyone for joining us today for our webinar, and we certainly look forward to seeing you again in the future, and keep an eye on the website for the recording and the slides from our presentations today and for announcements about our future webinars as well. Thanks everyone.